Welcome to this explainer on the clinical architecture of preventive health. Today, we're diving right into a high-yield matrix of malignancy screening and immunization logic. We've got a ton of crucial clinical data to cover to help refine your decision tree frameworks. So let's jump straight in. Here's our roadmap for today. We'll quickly cover malignancy screening matrices, focusing on colorectal and lung cancer, followed by breast and cervical logic. Then, we'll pivot to complex host immunizations, mapping out the pneumococcal sequencing matrix, and finally, wrap up with some specific immunocompromised case scenarios. Section 1. Malignancy Screening Matrices. Let's look at the primary screening algorithm pathways and their exact age interval boundaries. Okay, let's start with colorectal cancer. The standard screening window strictly opens at age 45 and runs through 75. You essentially have three primary pathways here: the gold standard colonoscopy every 10 years, an annual FIT test, or a Cologuard test every 3 to 5 years. Pretty straightforward baseline, right? But here is where things shift, the clinical variance box. If you have a patient with a first-degree relative who had colorectal cancer or an advanced adenoma diagnosed before age 60, that baseline algorithm goes right out the window. You strictly start screening at age 40 or exactly 10 years prior to the earliest family diagnosis. Plus, you force a colonoscopy every 5 years. It's absolutely crucial for catching those aggressive familial adenomas before they progress. Let's apply this kind of logic to lung cancer. The matrix requires an annual low-dose chest CT for adults aged 50 to 80. But there are strict rules. They need a minimum 20-pack-year smoking history, and they must currently smoke or have quit within the last 15 years. So picture a 52-year-old guy who smoked a pack a day from age 18 to 40. That's 22 pack years, and he quit 13 years ago. Our choice architecture forces us to order that low-dose chest CT, avoiding decoys like a simple chest X-ray or just offering reassurance. The absolutely critical number to remember here is 15. The second your patient has been smoke-free for more than 15 years, or if they develop a life-limiting illness, you immediately discontinue that low-dose CT screening. Hard stop. Now, the boundaries for breast and cervical screening are incredibly precise. Mammograms are slated biannually for ages 40 to 74. Cervical screening, though, is hyper-specific across the 21 to 65 age bracket. For ages 21 to 29, it's a Pap alone every 3 years. Once they hit 30, up to 65, you can either do Pap and HPV co-testing every 5 years, or stick with a Pap alone every 3 years. Section 2. Complex host immunizations. We're shifting gears now from malignancy boundaries to immunological mechanisms. When we look at pneumococcal vaccines for adults 65 and older, or high-risk folks aged 19 to 64, like those with chronic kidney disease, asplenia, HIV, liver cirrhosis, or diabetes, the difference really comes down to the immune response. Conjugate vaccines, like PCV15 or PCV20, induce T-cell-dependent B-cell activation. That gives us long-term memory. On the flip side, polysaccharide vaccines, like PPSV23, elicit a T-cell-independent response, which inherently has a much shorter duration. Let's talk about the exact sequencing matrix. Say you have a 28-year-old female on high-dose immunosuppressants for lupus. The current choice architecture actually forces a single dose of PCV20 over any live attenuated viral decoys. If you aren't using PCV20, the rule is you must administer the conjugate PCV15 first, then strictly wait at least 1 full year before giving the polysaccharide, PPSV23. But if that host is severely immunocompromised, you shrink that waiting period down to just 8 weeks. Which brings us to an absolute non-negotiable boundary, the number 200. Live attenuated viral vaccines like MMR, varicella, and the nasal flu vaccine are strictly contraindicated if a patient is pregnant or if their CD4 count drops below 200. In clinical practice, this boundary completely dictates our management. If an HIV patient with a CD4 count below 200 gets exposed to chickenpox, there is absolutely no way they can get the live varicella vaccine. Instead, the logic forces us to use varicella zoster immune globulin, which gives them immediate passive prophylaxis safely. The biggest takeaway from this matrix is understanding the severe systemic implications of these absolute limits. Overstepping that CD4 200 boundary or ignoring pregnancy contraindications with live vaccines can literally lead to systemic disease caused by the vaccine strain itself. So what other hidden boundaries are lurking in your preventative health architecture that could drastically alter your clinical decisions tomorrow? Think about it.